Some countries have been in the network for 4 years, some just joined last month. And by design, the network countries have different contexts, strengths, challenges, and resources to share. If every country's dashboard looked exactly the same, this would be a very boring learning network. The annual meeting is an opportunity to share lessons learned and to describe change over time. And as I mentioned in the previous talk, each year, the country teams complete a standardized online questionnaire, which informs our description of their model mix and contributes to the Sequin dashboard. So this is a multidisciplinary team in each country that reviews their information and helps give us this data. Next slide. I'm going to just give a little background to what we mean by model mix, and then a quick recap of the dashboard, which I talked about in more detail just in our previous session. So when we say model mix, we're really thinking about the different types of less intensive DSD treatment models that exist in various countries. And the whole idea behind DSD is that these are contextually specific, that they're based on the expectations and needs of recipients of care and the priorities of the health system. So we don't expect every country's models to be exactly the same, or to be, for countries to have the same number, the same type of models. But because at our annual meeting, we want to compare across countries, we do try to use standardized language. So that's what I'm going to describe now. We use a systematic approach to describe differentiated ART models, which we also call DART models. So we consider everyone on ART to be in a model, including those in conventional and more intensive models. They're not necessarily in the right model, but everyone is in a model. So people just starting ART may be in a conventional model. People who have advanced disease or comorbidities or psychosocial needs or needs for intensive adherence support may be in more intensive models. And for the purposes of this conversation, we categorize less intensive models for people doing well on ART by location. So that's the rows in this table on the right. So facility-based on the top row and individual on the bottom row, and by individual versus group design. So you'll see at the top left corner there, we have individual facility-based models. At the bottom right, we have community-based group models. And although countries can sometimes use different names for models, and their models aren't all identical, we do try to fit them all into this nomenclature for the purposes of comparing model mix. Next slide. Alberto, could you keep the cursor down so it's not moving around? Sorry, distracting. Okay, here is an example of the table that we use to describe the model mix from each country. Not all countries have all this data, but what we try to do is we say, okay, more intensive models include a conventional model for people starting out, virologic clinics, advanced HIV disease models. Again, these vary from country to country, but these are for people who are not what we used to call stable, and what Nathan pointed out, we're now calling established, or people doing well on ART. We categorize the less intensive models in these 4 categories. So facility-based individual models in the sort of orangey red, facility-based group models in the blue, community-based individual models in the yellow, and community-based group models in the purple. And so what we do is we ask each country to describe their model mix and to give examples of specifically what is happening in their country. Next slide, please. So you'll see that in this presentation from both Kenya and Malawi. We also talk about DSD program maturity. So using the Sequin dashboard that I described in our previous talk. So it uses a capability maturity model with 13 domains representing the necessary components for implementing DART at scale. It uses the 5 stages of maturity represented by the color scale. And each country has a multi-stakeholder team that stages themselves. So it's a self-assessment. And in the detailed presentations and the videos that are on the website, the country teams go into detail about both their model mix and their dashboard. Next slide. This is what the Sequin dashboard looks like on paper. Next slide. And this is just a reminder, yet another reminder, that all the details and information for the countries are on the website. And if you didn't look at them in advance of today's session, you can absolutely go back and look at them afterwards. But also as you plan for tomorrow and for Wednesday, you may want to pick what session you're going to and to watch those updates in advance. Next slide, please. So I'm going to just give a quick snapshot from Kenya and then from Malawi. It's not going to capture all the detail and great nuance, but we're going to discuss those in the panel. Next slide. So this is these are the icons that we use on the Sequin website. So we think about facility level coverage. We think about the percentage in less intensive DSD models, the number of major less intensive DSD models, and the number of groups for whom those models have been designed. So in Kenya, again, to oversimplify with apologies to Team Kenya, there's facility-based fast track model with appointment spacing. There are peer-led community ART groups. There are healthcare worker-led community ART groups. And there are also additional models for children and adolescents, although their data is not routinely reported. Next slide. This is a summary of Kenya's model mix, and I want to make a couple of points here. So you see that the gray pie piece there is the conventional model. In Kenya, as opposed to in Malawi and some other countries, 3-month multi-month dispensing, 3 MMD, is included in this gray piece of the pie in the conventional model. That's the way Kenya categorizes things. But so you see that the second sort of biggest piece of the pie is appointment spacing and fast track with about 26% of people in that model. These data come from the National Data Warehouse, which represents about 65% of the people on ART. So it's a pretty good sample. Next slide. This is a description of Kenya's dashboard in 2019 and 2020. So you see that in some domains that there has been improvement, and in some domains there's been a little bit of regression, and the team says that's due to more accurate staging. We see this a lot, sort of the more information we have, the more precise we can be about staging. But the big thing you see is that there's a lot of green. Kenya has a mature program. There's obviously still a little way to go, and you'll hear about that when we talk about their targets. But there is a lot of green on the Kenya dashboard. Next slide. The presentation on the website talks about challenges, it talks about adaptation for COVID, and it talks about achievements. I just picked a few achievements to highlight here. And so those include expanded training for lay workers on differentiated service delivery and improved involvement of recipients of care, enhanced reporting to the National Data Warehouse and the availability of DSD data, and the review of their differentiated care operational guide. So those are a few of achievements, and we can ask them about them as we proceed. Next slide. The challenges that Kenya flagged included suboptimal longitudinal monitoring of people in DSD models, so it's a little hard to follow people over time or to compare outcomes across various models. The need for a continued improvement in DSD supervision and mentorship at the community level, the integration of other services within DSD models, so family planning, management of non-communicable diseases, and hopefully some streamlined data flow. Next slide. And selected goals for 2021. I'm not going to read them all, but you'll note that one of them is that 60% of people in ART will be in less intensive DSD models. And there's an emphasis on expanding the diversity of models and the integration of other services into the less intensive models. Next slide. So that was, again, quick snapshot. Moving to Malawi, we'll do the same. So next slide. So Malawi has 4 major less intensive models, including 3 MMD, 6 MMD, drop-in centers, facility-based teen clubs, and outreach. Sorry, that's 4. But the MMD is sort of overlaps with some of those other models. Next slide. And you'll see in the pie chart, only 6% of people are in conventional models. The big 94% is split almost half and half between people who are in 6 MMD, so they get 6 months of drug dispense at a time, and people who are in 3 to 5 month MMD. So there's the way that Malawi describes their models. They tend to focus on the MMD because that overlaps with their other models, again, which are the drop-in center, teen clubs, outreach, and other. Next slide. And you'll see that Malawi has also made a lot of progress in the dashboard. So a lot of green, a lot of dark green in the dashboard. And the 2 areas of change, or the multiple areas of change since 2019 include coordination, training, and SOPs, which all moved towards the green zone. Next slide. Selected achievements, really hard to summarize, but the introduction of advanced HIV disease models, the development of SOPs and guidelines and policy documents also for advanced HIV disease, scaling up of 6MMD, improvements in electronic medical records, and improvement in commodity stocks. Next slide. And then again, selected challenges included assessment of the impact of DSD, some tricky issues with this double counting of patients between models, and other issues around stocks and eligibility criteria. Next slide. And selected goals include a focus on M&E strategy, more attention to assessment of the impact of models, expansion and diversification of models for teen clubs and for key populations, to integrate some DSD models into MCH and other programs, to expand the work that Malawi is doing in quality improvement, and also to sustain the gains. Next slide. So, and next slide again. So just quickly, I think we'll have the opportunity to ask questions of Team Kenya and Team Malawi, both live, and our moderators will facilitate that in the Q&A box. But to sort of summarize, in terms of shared achievements, both countries are working to diversify their DSD models to include advanced HIV disease. Both countries are expanding training and capacity building. Both countries have made great strides in monitoring and evaluation, but still want to continue that progress. And both countries are working to assess the sort of quality and fidelity of DSD models. So that's it for me. So next slide. Excellent. Godfrey, back to you to introduce the panelists.
Thank you so much, Miriam, for giving us a summary. If you have any questions or any comments, please let's use the Q&A box at the bottom so that we can ask questions and this can be responded to as we proceed. Depending on how well we are doing with the time, there might be opportunity to give the mic to 1 or 2 people towards the end to comment. I would like to introduce to you now the all-male panel. I don't know how that happened, but it's all-male panel representing the 2 countries. First is Dr. Lazarus Momanyi, DSD coordinator from NASCOP, Ministry of Health, Kenya. Then we also have Nelson Otoma, Executive Director of the Network of People Living with HIV and AIDS in Kenya. We also have Kenneth Masaramu, Adult Treatment and Care Advisor with CDC Kenya. Stanley Ngoma, Program Officer with the Department of Health in Malawi. Atenet Woku, Treatment Advisor, USAID Malawi. And last but not least, Lawrence Konyongwa, who is with the Network of People Living with HIV and AIDS in Malawi. I will also ask Miriam to also chip in here and there to assist me with the panel discussions. I would like maybe as a point of explaining how we will work, some of the questions or comments are going to be directed to Ministry of Health. Some might have a flair or a focus on PEPFAR. Others will also focus on the recipient of care, so that we are covering all the areas which are important to service delivery. The first question that I would like to ask the panelists is what do they feel about the progress towards scaling of DSD in their country over the past year? Do we feel that we are making good progress, even if we do have COVID? Do we still feel that we are on track? Maybe let's ask that first question to get things rolling. The panelists, you are able to speak, so feel free to respond. Maybe let's have Kenya first, someone from Kenya, and then Malawi.
All right. Thank you so much. This is Lazarus. I hope everyone can be able to hear me.
Lazarus, you're a little faint. If you could move closer to the microphone, that would be fabulous.
Okay. Is that better now?
Yes, much better. Thank you.
All right. Okay. So this is Lazarus from Kenya. So I think just to answer the question that has been asked, overall, as a country, we feel that we are making quite good progress in the last 1 year towards scale up of DSD in Kenya. And I know even the coming of COVID-19 actually was more, I would say, like a blessing in disguise, in quotes, because we've seen more acceptance and receptiveness to some of the DSD models, like multi-month dispensing, some of the community models that were previously struggling to have people to be able to pick the ART from the community. We have seen more recipients of care accepting now to be able to receive the ART from the community. And also we have seen even beyond the treatment program, other programs like the key populations, HIV testing services, coming up with the innovations in terms of DSD or differentiated service delivery in those program areas. I know so in our presentation, I know probably didn't come out, but we've seen a scale up of multi-month dispensing. And when you look at the overall number of people who are more than 3 months of multi-month dispensing of ART, we currently have over 70%. And this is an increase from the previous years. Because of not just because of COVID, but because of some of the efforts you've done in terms of giving people more months of treatment to have and reduce the visit to the facilities. Of course, you also mentioned that one of the challenges we have over time is really the availability of data for DSD, because this was not previously reported through the KHIS, which is the routine reporting system for the HIV system. But now through the National Data Warehouse, you've seen more data being reported. And I know that as Kenya is planning to transition more sites towards EMR and from paper-based to EMR sites, this is going to help us to have more data available. And finally, I think the other progress we've made is really that we've seen more engagement with people living with HIV and recipients of care. For example, the training that we did for community models, we even had some of them as facilitators, and we have seen more discussions, more receptiveness towards DSD models, not just as a country, but also among us, the people living with HIV. Thank you so much.
Thank you so much. A response from Malawi, and then after that, I'll hand over to Miriam for the next question. Malawi, you can go ahead.
Maybe I can start. I'm Lawrence Konyongwa. I think I can say that there has been a lot of progress in the last year in terms of our DSD models implementation. However, COVID-19 affected our implementation, whereby we had a number of restrictions and also improvements in certain areas. For instance, there were restrictions on teen clubs due to the gatherings and the playing that the children have, the adolescents have, during teen club sessions. However, although this was tackling the issue of COVID-19, but it is a model that the adolescents like, and they're able to be assessed properly. So the way it was introduced, the way the ban was introduced, I think it was also so abrupt. There wasn't much community consultation because it was like a state of national disaster, and ministry had to move in to do a lot of restrictions. One other restriction was on default tracing by expert recipients of care, who were also told that they could not continue to go to the villages to encourage people that are defaulting on treatment. So this has affected other people that needed the encouragement to continue on treatment. Probably we'll be finding out more in terms of the impact that these restrictions had on the adherence as the different surveys are being carried out. However, we have also seen a lot of improvements, and some people are saying some of the restrictions, some of the guidelines that were put on during the COVID-19 pandemic need to continue. For instance, the spacing at the waiting area in the various clinics, the spacing has been tremendous because it is strictly 1 meter apart, and there are marks that tell you where to sit as you want to be to have your consultation. So this is good, and people say this has to continue even when COVID is over, as well as even the reception by the healthcare workers has been good because there was less congestion in the clinics as opposed to the time there was no COVID. But overall, I think you saw from the presentation that we have done well in certain areas of our dashboard, and we need to improve on a few areas. So we are on green on most parts. There has been also a lot of involvement by the people living with HIV sector in technical working groups, in various meetings, and we hope that this is going to continue. Over. Thank you.
Excellent.
Thank you so much. Over to you, Miriam.
Thank you. So I'm looking at the questions in the Q&A box. There are a few questions in the chat box, but we prefer you put them in Q&A so that we can answer them by typing as well as out loud. But I wanted to ask Team Kenya a question from Dr. Apollo in Zimbabwe. She says, can Kenya share their experiences integrating DSD with family planning services? So you could decide to answer this, or you could decide to answer it by typing. But I think I will ask maybe Lazarus, if that is a question that you want to answer live or in the text box.
I could just answer it live.
Mm-hmm.
Yes. So thank you for that question. And I know family planning is one of the areas that we really looked at in terms of how we can integrate to ensure that even women who come for the less intensive models who are receiving help in the community, and those who come even to the facility, I do not need to come to make additional visits for the family planning. So one of the things that we've done over time, of course, is to ensure that within our clinics, we have ensured that there's integration of family planning, and specifically within the CCC, the HIV clinics, we have now some of the family planning methods, including the long-acting methods being provided. We have also additionally, for some of the other models, like the community models, we have seen where some of the people have modified, whereby where there's a healthcare worker-led model, then they're able to go and provide some of the family planning within the community. And we have also seen merging of the visits, whereby the family planning visit or the clinic where the woman or the adolescent girl is supposed to get the family planning jab or the injection is matched with the clinic visit. And this matching of the visit has really helped to ensure that they don't make additional visits. But overall, there's still some work to be done to ensure that we have full integration of family planning within our DSD models. But I believe that we are making some progress towards that.
Great. Thank you very much. And welcome back, Priscilla. There was some internet connectivity for Priscilla, but she is back as one of our co-moderators. I'll ask one more question, then I'll hand back to Godfrey, and then we'll hand to Priscilla to keep asking questions. So I wanted to ask a question of, let's see, of Kenneth. So Dr. Masamara in Kenya, what investments is PEPFAR making, thinking about sort of the next PEPFAR year, the next COP year? What investments are you making or planning to make to support monitoring and evaluation of DSD? I know there's some questions we'll come back to about the impact evaluations, but just in terms of routine M&E, is there anything that you wanted to highlight in terms of PEPFAR's investments?
Right, so thank you very much for that important question. So let me just step back and also just contribute to some of the things that Lazarus had mentioned. So PEPFAR has been very committed to promoting patient-centered models. The conversation started back in 2016, and at policy level, we were able to have it in the 2016 guidelines, in the 2017 operational guidelines, and finally in the 2018 ART guidelines, really detailing both the clinical characteristics, the contextual innovations, as well as the different populations now taking to the fore. PEPFAR has, through COP funds, appropriated funding to support the Ministry of Health to move this agenda forward, not only in the policies that I've mentioned, but also in terms of implementation. And while you saw our data there, facilities, implementing partners that PEPFAR is supporting have been able to move forward with the agenda. Currently, we have almost 100% of PEPFAR supported sites implementing one model of DSD or other, and about 75% of the treatment cohort on multi-month dispensing. The challenge, and which is now addressing the question, has been to ensure that the data that is collected and analyzed and synthesized and disseminated is also the same data that is available at the national level. And as Dr. Lazarus had said, the challenge for Kenya, and it has been a big challenge for a number of years, is that has not been in total synchrony. So the tools have not really been able to capture some of the required data for DSD models. However, we are moving forward, especially leveraging on the electronic data. So from the EMR to the central repository, that is the National Data Warehouse, where some of this data is currently being collected. And what you saw is a representation of what was collected and synthesized in the National Data Warehouse. So PEPFAR has provided investments related to supporting the National Data Warehouse, investments relating to funding partners to expand EMR coverage, currently at 78%, but hopefully in the next year we'll go all the way up to 90% and if possible 100%. Part of the conversation is also how to revise the tools when the time comes for revising the instruments to collect the data. As you know, in as much as we are moving towards EMR, there are still facilities that are paper-based, and having the variables needed for differentiated service delivery captured within paper tools. So that is a conversation we're having with the Ministry of Health. So when the time comes to revise those, then we will be able to support that process. So in summary and in conclusion is PEPFAR is very committed, really strengthening the use of electronic systems to capture that data, expanding EMR coverage of that data, and ensuring that we have an integrated system such that what we collect as implementing partners is also what is available at the national system. Over and thank you.
Great, thank you so much. Godfrey, over to you.
Thank you so much, Miriam. A quick question to Malawi from the chat box before we hand over to Priscilla. The question is from A. Sankani, and they say it appears both countries are struggling to assess the impact of DSD. What are the challenges? What have we planned to do in 2021 to ensure that at least we are able to better assess the impact? A brief response from Malawi.
Hi, this is Antana from Malawi. I will attempt to answer that specific question. So I think part of the response is related to the question earlier in terms of what kind of monitoring and evaluation systems do we have to monitor the implementation and the impact of DSD services and scale up in our countries. I think for Malawi, a major part of our information system, data system for monitoring and evaluation within the treatment program is the electronic medical record system. And in FY20, last fiscal year, as part of COP19 plans, there was a significant deployment of AMR systems to almost all ART systems. And as you might have seen from the Malawi country update, around 95% of all ART sites were able to generate the standard Ministry of Health's ART reports electronically. So DSD services, particularly multi-month dispensing, which is the primary approach that the Department of HIV/AIDS has taken, is in terms of data on multi-month dispensing. We can have uptake data by age and sex. We can build into the MR system. But we have that system established, but all the different data elements that would help us in terms of assessing the effectiveness and impact of DSD systems, the work is not yet complete. Right now in this fiscal year, the PEPFAR Malawi HIS partner is working closely with the Ministry of Health and other PEPFAR service delivery partners to identify additional data needs and further improve data accessibility through expanded use of dashboards. We have data that shows these are individual assessments, evaluations done by implementing partners to demonstrate, for instance, whether or not the clients who have been started on multi-month dispensing, the 6 months multi-month dispensing, how they are doing in terms of retention, how they are doing in terms of viral suppression. And some of the data that we have, it strongly suggests that these, for instance, multi-month dispensing 6 monthly leads to a high retention and high viral suppression. But those data are coming from few facilities. But the way forward for us is, as we continuously evolve our electronic medical record system and also build our capacity of analyzing the data from the electronic medical record system, would be in a better place to tell the effectiveness, how well our DSD models are working without a lot of manual work going through the paper master cards. So right now, it mostly depends on individual efforts by implementing partners in the Ministry of Health, which involves a lot of work. But we are hopeful that, as the AMR system evolves, as we build some additional data presentation capabilities, that process would be easy and would have a better idea of how our DSD models are working. Thank you.
Thank you so much. Over to you, Priscilla.
Good afternoon, everyone. Good morning. Those of us listening, joining from where it's still morning. My name is Dr. Priscilla Molenga. I'm joining in from Zambia, a beautiful country of Zambia. Though I've seen it's indicating I'm the PMTCT coordinator, yes, I am. But for this activity, I'm co-moderating with my colleague, Geoffrey, because I am the national DSD coordinator for the country. I lead a team called the DSD task force in the country, whose responsibility is to coordinate and provide that key leadership. So the DSD task force in Zambia comprises Ministry of Health and implementing partners and funding agencies. I think for now you can, I think that's enough for now to know. And I had joined in ready for this session. And sometimes, you know, they say things, the unexpected things happen, or should I say life's embarrassing moments. Yeah, from nowhere, it's pouring heavily outside. And somehow we had some power outages. So I had to quickly rush like lightning to go somewhere where I could connect and be part of this session. So my co-moderator, Godfrey, kindly take it up as I just catch my breath. Thank you.
Excellent. Thank you so much, Priscilla. And we all understand, we have all had that similar moment where the internet did not work at the key moment when we needed it. So welcome, and not a problem. I am going to pull another question out of the Q&A box, but also panelists, feel free to type in answers because we have 11 great questions in there right now. But I wanted to refer this question to Nelson. So it's a question from Marinette, and she asks, for Team Kenya, what specific activities have you done to increase acceptance and receptiveness of DSD models, both at the facility level and also among recipients of care?
Thank you very much for having me in. I'll go to your question. Before that, I wanted to touch very quickly on what Dr. Lazar has already mentioned, how we feel we have made, or the progress we've made during COVID with DSD. And yes, as he said, surprisingly, DSD moved some steps forward, maybe forcefully because of COVID. And what I'm saying is that with the advent of COVID, the Ministry of Health through NASCOP gave guidance and which clarified to healthcare workers and recipients of care the need to have ART in a manner that was described, which fits well with the DSD models, and particularly the facility-based models. And I also need to mention very quickly that two things made recipients of care become alert and also to move very quickly to strengthen their side in terms of demand. One, I think there were rumors initially with COVID that ART in whatever form could manage it or prevent it, and that has since been clarified. But it helped to push people to closer to ART and to demand that we need ART, particularly during that time, and to stay away from facilities. So that fits with the DSD. But I also want to say the second thing is that every agency, every technical agency dealing with HIV, UNAIDS, WHO, CDC, they have clarified to us during this COVID that for persons living with HIV who are virtually suppressed, they stand a better chance of staying free of COVID infection or even managing if infected. And I think that also sends signal to recipients of care to demand more. But getting to the question at hand, what specific activities? We have a discussion even before COVID, and this discussion came in when countries were being asked to move, in addition to CD4 count, to also check viral load. people understand why viral load is important in terms of checking your wellness when you are on ART. So for we in NEFAC, although I can come back to this back later because I saw it's one of the questions, we had to sensitize people living with HIV as part of our treatment literacy efforts, explain what viral load is and how to keep it to undetectable levels, and also what we meant by durable virtual suppression and the importance of that, which is the benefit of knowing your status and going on treatment to persons who are living with HIV. Now, among the people who are trained, we selected a few champions, and these champions are the ones who are going to reach out to their peers, or young people, or KPs, or adult persons living with HIV, and explain what this is. Initially, I think the persons living with HIV moved ahead of healthcare providers. So we had to demand that I've been here for the last 1 year. I have not seen my viral load. And when this was rolled out by the Ministry of Health to people who could access it, I think we created dialogue, because as I've said before in sequent forums, if you go to a facility and you are virtually suppressed, what clinician does or the nurse does is to check a computer and tell you are fine, go home. Or you, in Swahili, they say, we uko sawa. And we have to go back to get a few champions to create dialogue. What does being fine mean? It may be fine because probably I am actually suppressed, but what if I go home and die of other conditions? So that is the dialogue that we've been creating, and asking communities and recipients of care to ask questions around viral load and the result that they get, whether they get it through their body or whether they get it in a facility, to make sure that they adhere to that. And what is important for them is that the moment you keep your viral load low, then the wellness and the quality of life is guaranteed. The other point we've emphasized to recipients of care is that it may not be a permanent thing. It's not lifelong. So you need to keep on checking, and you keep it low by doing your medicine, but you still need to periodically adhere to the guidelines of checking so that you see, in case there is any challenge, then you pick up a discussion to discuss around your medicine or discuss about the practices of having your medicine. So from our end, that's how we've approached it, to make sure that people understand, and we continue to educate adolescents and young people living with HIV and the newly diagnosed, so that they understand viral load and why it is important to keep checking it. Thank you.
Thank you so much. The next question is for Stanley, and is from Burundi. The question is, DSD is more directed to clients who are stable and who are adherent. What are we doing for the unstable clients? Any experiences from Malawi? Over to you, Stanley.
So hi, everyone. Great. So for our approach in regards to the DSD service delivery, it's actually targeting both population, the unstable ones and the stable population. And we've got a criteria for that. And so probably this, what you see also, those that are unstable, they are having like more intense like visits. So the interval at which the supplies are given to them, and also the visit to the facility, you find that it's more frequent because they're unstable. So we have to keep them and monitoring them closely up until they stabilize, and so they can be shifted to the less intense models. And I think in the presentations that we had pre-recorded already previously, we had talked about some of the success stories that we've registered over the past year. And so that's the adopting the concept of advanced HIV disease within the HIV program. And so it's a targeted population group that are living with HIV. So either presenting in the late advanced stage of HIV infection. And so the model of care that they have to get into might not be the same as those that in the conventional population. So they have to get into a model that would work better for them. So in short, I can say the approach is actually different. So we are targeting both population, the unstable and unstable patients, but different models of care that we offer them. Thank you.
Thank you so much. A quick response from Kenya to that question. Maybe Lazarus, you can jump in.
Sorry, I missed that. I had a problem with my.
Okay, the question is, what are we doing for the unstable clients?
Thank you. I think since actually we've had a lot of conversations, and especially even recently during the advanced HIV disease workshop, and one of the things that we are doing for the clients who have high viral load. Currently in Kenya, we are implementing what we're calling the viremia or the high viral load clinics, and we've really seen this scale up where the recipients of care who have high viral load are booked on the same day, and they're able to receive group counseling and also adherence support, as well as have the other issues addressed. And we've really seen some good outcomes from some of these clinics. We also have for the patients who have advanced HIV disease. We have also seen some of the streamlining on how the approaches and some of the SOPs, how they're managed in the clinics. And I know that in Kenya, we still have a challenge in terms of coverage of CD4 for the patients who are new and those who are returning to care. And this is one of the areas that we are, as we revise our guidelines, we really want to strengthen the implementation and measuring of CD4 so that we're able to identify these recipients of care who have advanced HIV disease and be able to put them on appropriate management. But I think overall, I know that previously our models tended to focus more on the stable clients, but as we move on and even as we expand our models within our national guidelines and policies, then we really want to recognize those who are not stable, the unstable clients, to ensure that they're also receiving appropriate care. Thank you so much.
Thank you
let me
so
just
much.
add.
You can go ahead.
Yeah. So thank you. Yes, and just to add to what Lazarus has said, I know, when you think about unstable patients, you mostly are directed towards their viral load, but the program has also been quite effective and strong in really supporting other aspects. For example, psychosocial support, for patients interrupting treatment, screening of STI, scale up of TPT, as well as facilitating TB screening, all of which are important to ensure that these patients do not eventually miss their treatment because of these other antecedent issues. So that has also been quite deliberate and quite strong in the program. Thank you.
Thank you so much. This session is very well attended. As of now, we have about 126 participants. Over to you, Miriam, for the next question.
Yes, thank you. Okay, I have a question that I'm going to direct to Kenneth. And it's from Priska Kasonde. So she asks, apart from multi-month dispensing that's done relatively well with COVID, so it's because it's been accelerated in the context of the COVID response, how have the other models done during this COVID era? So we heard from Lawrence that some of the adolescent, like the teen club models in Malawi, had been canceled. In Kenya, apart from scaling up MMD, have there been any other impacts of COVID on other models?
Yeah, so thank you for that. Yes, so COVID also brought in some changes, as has been said before. Yes, we did scale up MMD, and MMD has mainly been facility-based. We did also see a little uptake on the community-based models, and these were contextual to certain geographies. For example, Turkana in the north, a few areas of Western Kenya that also saw an increase in terms of the uptake. Traditionally, Kenya has mainly concentrated on the facility-based models, with a small percentage of recipients of care opting for community-based models. So that slightly increased. Of course, the mode of delivery was affected by COVID, with less in-person interactions, especially when delivering drugs, but for the cases that we had to interact with the recipients of care, maintaining the non-pharmaceutical interventions for preventing, the spread of COVID-19. When talking about populations, we also did see an increase in terms of uptake of models related to certain populations like children. So we have what we call permacare, where it's a family-oriented integrated model. So where the family and the child are linked, the caregiver and the child are linked and are categorized as whether they are generally stable or unstable. And so they're given their care together. So that essentially also scaled up a bit. In terms of supporting activities, including psychosocial support, to help in these models, in-person activities decrease, but we did see an uptick of virtual engagements to some of these models. So really, I think for Kenya, we have generally been strong on the facility-based models, on the multi-month dispensing. Contextually, some regions have had an increase in community-based ART models, especially in Western Kenya, in Turkana. But we also saw that the physical interactions went down, especially when delivering some of these models. Thank you.
Thank you so much. There's a question here from Raphael. I'll direct it to Lawrence. He's asking, what is the situation of stigma and discrimination against people who are living with HIV and AIDS? And how has COVID affected that? Has it increased it? And if so, in what way?
Thank you very much. The issue of stigma and discrimination, I think, has remained constant. There are some efforts to ensure that stigma and discrimination has been eliminated. However, we continually see issues of stigma in communities, as well as self-stigma. So based on our last stigma index that was carried out in 2016, we noted that there are pockets of stigma and discrimination that need to be addressed at facility level, as well as at individual level and community level. We have in Malawi the HIV and AIDS Prevention and Management Act, which has also tackled issues of stigma and discrimination to the effect that a person that is stigmatizing a person living with HIV will be fined. So with COVID-19, what I can say is that we have not really experienced any change in terms of the levels of stigma and discrimination because of the COVID-19. We need to do another study to find out this current situation in the country. However, at the moment, I think the levels of stigma have remained the same. We also have noticed some stigma in places of employment, which also need to be checked. And the issue of self-stigma for breastfeeding women who are attending PMTCT services, as well as EID services, that has also been noted. And I think it will be addressed in our programming and our national strategic plan. Over.
Thank you. maybe briefly, Nelson, what has been the issue of stigma for individuals who are living with HIV and AIDS in Kenya? Briefly.
Yeah, thank you very much for this question. I had not thought about that line. I think we probably need to consult more and do researches to find out. But just from anecdotal evidence, I think our discussions when we meet virtually or when we do small support groups is that COVID may end up reducing the stigma associated with HIV because we realize actually there's nothing around HIV to fear and to stigmatize. I think COVID is carrying part of that stigma with it and going with it, because I think what people were stigmatizing initially was the sickness and the death associated with HIV, because that is going down because of the widespread ART. And then COVID came in with instant deaths and which is more scary. I think I'm just making preliminary comments, but our research is needed to find out. And in my opinion, I think after we are through with COVID and the worst of it, the stigma around HIV and AIDS may reduce or even be eliminated altogether.
Thank you, Nelson. Over to you, Miriam, for the next question.
Great, thank you. I'm going to direct the next question to Lazarus, and it's a question from Dr. Apollo in Zimbabwe. She says, it looks like Kenya has done well in improving the quality domain on the dashboard from orange to green. How did you achieve this?
Hi, this is Lazarus. So one, I think, as I said, from our national data warehouse currently, we are able to monitor, because you have individual patient level data, we're able to monitor in terms of those who are on different DST models, what is the outcomes in terms of retention and viral load. And so we're able to get this data, and it's actually shown that we are doing well in some of those models for those who are on, for the outcomes that we measured, so viral load outcomes and retention. But also in Kenya, as you know, last year we also did what we're calling the QI DSD integration, and within it there was also a study that we're doing called program quality evaluation, where we were looking at the outcomes of DSD within those facilities where this was done. And from that, we were able to get some very good data that showed very good outcomes in terms of those recipients of care on DSD models. So combined, looking at the evaluation that we've done, and from the study and also from the data that we have on retention and viral load, we've been able to see some improvement. But in terms of what we have actually done, over time, because of some of the engagements at the facility level, the capacity building in terms of patient care, the use of viral load for timely decision making, and some of the interventions that I know Ken has mentioned, like the psychosocial support and the adherence, and for those recipients of care, that's some of these models, then we have been able to see some of those outcomes improve. I know that one of the things that really, as we mentioned, one of our gaps still have is still longitudinal monitoring of these recipients of care, especially for paper-based sites. And we've seen some of the sites using what they call longitudinal registers, but this is just in a few sites implemented for some implementing partners. So as we review our guidelines, this is one of the areas that we really want to strengthen in terms of longitudinal monitoring of the recipients of care on the various DST models, and even being able to measure the outcomes between various DSD models, and being able to say that the patients or the recipients of care on this model community health group are doing better than fast track or vice versa. Thank you so much.
Great. I have one more question and then I'll hand it back over to Godfrey. We only have about 7 more minutes. So I feel like we're having this conversation and that's really active, and I want to applaud everybody's engagement. Keep putting questions in the Q&A box. We'll answer them by typing in text if we can't get to them out loud. But I have the question that I want to ask is first for Antenna and then for Kenneth. And it's about something I noticed in the draft COP21 guidance. So the draft, anyway, I know the final guidance isn't out, but the draft recommended integrating services for non-communicable diseases and other health challenges into HIV programs in areas and subnational units, so districts, provinces, counties, where there's strong performance. So there was some specific guidance about what that meant. But so it sounded as though there was at least the potential for expanding DSD programs to include family planning, to continue to include TB services, but also to include services for non-communicable diseases like diabetes or hypertension. So first to Kenneth and then to Etana, is that something that you're planning to do in Kenya and or Malawi?
Right, so thank you for that question. And yes, we did see that in the language of the draft COP21 guidance. It's something that, has come at the right time. It's a conversation we've had for a long time, especially with the fact that our patients or our recipients of care have generally been stable. Their mortality, or AIDS-related mortality has decreased. They are living longer. The prevalence of non-communicable diseases have been going up. A few years ago, in last year, 2019, based off on a longitudinal study that we did for a treatment cohort between 2003 and 2013, showed that the prevalence of non-communicable diseases in a representative of about 50 sites across Kenya was up to 11% just for hypertension. And looking at it, from a service delivery level, clinicians would typically see and manage patients with HIV, but also on the side, you'd see, you'd notice that either they have hypertension or diabetes. And it only makes sense that it is now time to integrate, some of the clinics they go to with our ART clinics. This is definitely something that the PEPFAR program in Kenya will pursue. First looking at the policy, but also the easy picks in terms of implementation, just to see how we could synchronize something basic as clinic appointments, between, say, the diabetic clinic and the HIV clinic, and seeing a way to merge them in some way, or to take over aspects of some of the management, and that would entail, mentorship and training. So it's something that we are looking forward to, something that we are keen to support. Thank you.
Excellent. And you know what? I asked this question of Antenna as well, but I'm looking at the time and I'm realizing that we probably don't have time to continue this discussion right now. So apologies, because I want to know, I know Malawi has a lot of work being done with HIV and NCDs as well. But so we'll defer that question. And we do need to wrap up. So what I will do is I just wanted to point out that some of the questions that we have not answered are probably going to be addressed in the parallel sessions that are following in 30 minutes. So I wanted to point out that then you now have to choose between session 3A, which is on viral load testing. And I know we had a question about viral load turnaround time, so that could be asked there. Session 3B is on differentiated maternal and child health services. And I know that family planning will be included in that discussion. So Helen, your question about family planning will probably be addressed there. And then there's several questions about impact assessment. So Sydney Rosen has pointed out that there are efforts underway, the AMBIT team and others, there are efforts underway to gather data that will help with impact assessment. And for AMBIT, that's particularly in Malawi and Zambia. But another approach to impact assessment has been these DSD performance reviews, and those will be discussed in session 3C. So I'm delighted that we had such an active discussion, and hope that some of the questions that weren't answered now can be answered soon. And I will hand back over to Godfrey.
Thank you so much, Miriam. I would like to thank the panelists, Lazarus, Nelson, Kenneth, Stanley, Atene, Lawrence, for such a wonderful discussion, as well as all our participants. And I would like to remind you that the next session will start at 10 a.m. New York time, 5 p.m. Freetown time, 6 p.m. Pretoria time, or rather 5 p.m. Johannesburg time, 6 p.m. Nairobi time. Thank you so much for a very interesting discussion.
Excellent. So thank you, everybody. And we'll see you all together in plenary tomorrow and in the parallel sessions in 30 minutes. Thanks so much. And particularly thanks to our panelists.
And thank you, Miriam, for standing in for me.
I could never stand in for you, Priscilla. But it's not a problem. Between you and me, we've diluted our all-male panel, so it's all good. But I did want to really personally thank Lazarus, Nelson, Kenneth, Stanley, Antenna, Lawrence, and Godfrey for a fantastic discussion that we hope will continue over the next few days. Thanks, everybody.
Thank you so much.